البث المباشر ابتدأ. تفضلي دكتورة.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. أنا اسمي راني عطا، طبيبة تخدير وعناية مكثفة، بشتغل في إيرلندا. أولاً بحب أرسل تحية شكر وتقدير واحترام لكل الكوادر الطبية ولكل الكوادر المساعدة الشغالين في الخطوط الأمامية لمجابهة جائحة الكورونا. شكرا جزيلا على المجهود اللي انتم بتعملوا فيه، وكلنا عارفين الوضع الصعب، في الحقيقة هو الوضع الصعب throughout العالم كله، لكن يمكن في السودان الحالة الاقتصادية زايد العبء عليكم زيادة، فشكرا لكم على كل اللي بتعملوه. اللايف ده مفروض انه يكون جزء من سلسلة بتاعت لايفات بتاعت تيتشنج، ف I hope إنه يطلع كويس وتستفيدوا منه. طيب، اللايف اسمه أو العنوان بتاعه Practical Guide for the Intensive Care Management of Patients with COVID-19. وأكشلي لو لاحظتوا هو مختلف من العنوان اللي طلع initially في الإعلان، لأنه أنا I felt إنه I need to share with you practical guides دي initially، وبعد ذاك we can move on للميديكال مانجمنت. التوبيك كبير و definitely هيحتاج like more lives يعني to cover it all. طيب، دي data and news بس من as per today. زي ما شايفين الرقم ده هو ال confirmed global cases as per 13th of June today. دي ال deaths ودي ال total recover. في أخبار مختلفة من العالم كله، يعني بيجين عملوا لوك داون بعد ما حصل سبايك للانفكشنز بتاعته. مكسيكو الديلي ريكوردد كيسز بتاعتهم increasing. بعد هم they are preparing to reopen. Brazil had the world's second highest COVID-19 death toll after overtaking UK. وفرنسا they are preparing to lift the border restrictions بتاعتهم. And I brought this slide عشان to show just إنه the situation is different from day to day, kept changing، والحاجة دي حاصلة في كل الحتات. ف it's difficult to predict إنه هيحصل شنو بكرة في السودان. الكيسز حتزيد قدر شنو، حتنقص. It's just difficult. فأنا أفتكر إنه we have to be prepared for أي حاجة. As we all know, SARS-CoV-2 is the virus responsible for the coronavirus disease pandemic. Transmission is predominantly via inhalation of droplets containing a virus. Clinical features, they are variable and non-specific. Can be cough, fever, shortness of breath. I'm sure you all notice إنه هم patient they present with different clinical features. They might present with GI symptoms. I know in Sudan people said like they present with like malaria-like disease. Patients with proven or suspected infection must be isolated and treated by staff in appropriate PPE. We all need PPE, we need training in PPE, and we need to know how to do like donning and doffing. 15% of patients with COVID-19 اللي بيحتاجوا hospitalization, we expect them to become critically unwell with respiratory and other organ failures, and they might need to come to ICU. Pulmonary microvascular thrombosis and pulmonary embolus may be prominent feature of the severe disease. والعيانين اللي بيحتاجوا intensive care admission They are at high risk of prolonged mechanical ventilation, failed extubation, acute kidney injury. 20-25% منهم they are going to need renal replacement therapy. If I start talking about severe COVID-19, the key features of the disease is hypoxic respiratory failure and multiple plus or minus multiple organ failure. They might come just with a single organ failure, or they might come with they might present with like multiple organ failures. We all know that the current mainstay of treatment is supportive care, and currently there are no specific treatment for patients with COVID-19 that have been demonstrated to improve outcomes. It is only supportive treatment. As I said إنه هو البرزنتيشن ده حيكون I will go through few practical guides that will help manage patients with COVID-19 either in ED, in theater, in ICU, or in the ward. Okay, I'm not going to go like into the pathophysiology or the lab results or antibiotics. I'm not going to go into that today. So we start with the most important thing, I think, for anesthetists is the airway. So intubation represents a high-risk procedure for both patients and staff. And the highest viral loads are found in the respiratory tract, and those correlate with severity of illness. So to secure the airway, or when you are securing the airway, protection of staff is an important aspect of airway management. So what we need for intubation, you need an intubation team. For intubating a COVID-19 patient, we need a minimum number of people around the patient. As I said, we need to protect the staff. It's a high-risk procedure because of the aerosolization. You need to do the intubation in either a single room or in مثلا مركز العزل where all the patients are diagnosed COVID-19, or in like a theater room that is dedicated for intubation. Like we can't just do intubation in a ward مثلا with 10 beds and you're intubating a COVID patient. This is going to be high risk for other patients and for the staff actually. So ideally, if we can get even in ED, get like a dedicated single room for intubation, or we agree, like you guys agree locally that the intubation of the patients are going to happen in the theater, where like in a single rooms of the theater rooms. So you need, ideally, you need 4 people for intubation. You need an intubator, we need an intubation assistant, drug administrator, and a runner. The intubator, it's very important to say that the intubator has to be the most skillful personnel available. Intubation of COVID-19, it's not for a junior registrar who want to like train or to practice intubation. It is not for the anesthetic technician who wants to learn how to intubate. It's a high-risk procedure, as I said. I keep repeating that. It's a high risk for the staff and for the patient. The patient is usually when they need intubation, so they are hypoxic. You don't have much time like to try and intubate like first trial, second trial. So you need someone who can do it on the first pass. So that is the intubator. So just my message for the junior registrars or for people who are starting the rotation or people who want to practice intubation, do not practice on a COVID patient because it's high risk. Second person, you need an intubation assistant. this it's a person who is going to hand you the tubes, the laryngoscope, the suction, inflate the cuff when the tube is in, help you like hold the tube while securing the tube with a tie or with a sling. And the third person is a drug administrator who is going to give the medication. I will go through the medication later. The fourth person is a runner. And the runner is someone who can stay outside the room, but he's available if he's needed. Like if you discover just in the middle of the intubation that you are missing something or something is, you need something, so you can call them and they can help you, or if you need an extra hand. Other than that, everyone should leave the room and should not be there. And this one is not only for the intubating COVID patients, like it should be the practice these days, even for elective intubations these days, like if someone is coming for appendix, we should adopt this minimum number of people in the anesthetic room for intubation. And of course, all team members should wear PPE. What to use for intubation? We know that the current guidelines is recommending to use a video laryngoscope. But if you don't have a video laryngoscope, it's okay. If you are experienced with using a normal just a laryngoscope, not a video laryngoscope, just use it. So it doesn't have to be a video laryngoscope if it's not available. Like we can't say like we are not going to intubate the patient because we don't have video laryngoscopes. Few words on airway still. So planning and assigning of roles. It's hard to communicate once in PPE. So it's better at the start ناخد plan for the intubation. So we get our intubation trolley ready with all the laryngoscopes, different size of tubes, bougie, suction. You check your machine. You communicate with the other people in your team, like how much medication do you want them to give, like the anesthetic drugs and the muscle relaxant, and what is your plan B if the intubation مثلا turned to be difficult. So it's better to have a plan and to assign roles from the start, because like once people in PPE, communication can be very difficult. People are in mask and visors and ممكن الناس ما تسمع بعض حتى يعني. Pre-oxygenation is very important. So if you have time, definitely so pre-oxygenate for 3 to 5 minutes and use two-handed technique to ensure tight fit of the mask. I will share a picture of the two-hand techniques. So you want a good seal with the mask عشان ما يحصل أي leak of the leak and بعد ذاك تبقى risk for aerosolization and infection for other people. We usually do rapid sequence induction for COVID patients. So medications, you can use whatever available. We can use ketamine 1 to 2 milligram per kilogram body weight, plus or minus fentanyl if it's available, 1 mic per kg. For muscle relaxant, either use rocuronium, give a good dose if you are using rocuronium, 1 milligram per kg. So even you can use 1.2 milligram per kilogram body weight to allow you to intubate within 1 minute. Or succinylsonium, 1.5 milligram per kg, again, is a suitable muscle relaxant. I think succinylsonium is available in Sudan and no problem with that. We avoid hand mask ventilation if it is safe for the patient. Try to do a proper rapid sequence induction and intubate within 1 minute. Avoid hand mask ventilation. Again, like we are trying to avoid any aerosolization. But if the patient is like severely hypoxic and you need to ventilate them, you can use 2 hands and ask your assistant to ventilate with low pressure and low flow. We have to inflate the cuff prior to ventilation. Once the tube is in, you inflate the cuff, you connect the circuit, and then you check if the tube is in the right position. Then you start ventilation. Do not start ventilation before inflating the cuff. All these measures is to prevent aerosolization. And to avoid accidental circuit disconnection, which can happen, push and twist all connections. And this can be done before, like, can be done as part of the initial checklist. Is that like you push and twist كل connections to make sure it is secure. This picture of the 2-hand ventilation, or 2-hand actually, the way that you hold the mask tight. So we used to say like use the C and E, but now it's like you can use a V and E actually with your 2 hands to make like to make sure that you have a very tight seal. Again, to continue with the airway management, we have to use HMEF filter between the catheter mount and the circuit. After stabilization of the patient, wet circuit should be used for COVID-19 patient receiving mechanical ventilation, and we need to check the filters at least 12 hourly for fluid collection. If available, ideally we should use inline suction to minimize circuit disconnections. If disconnection necessarily, consider clamping into tracheal tube. لو عندنا inline suction, this is ideal عشان ما نضطر to disconnect the tube and do suctioning, and again like risk of spreading the virus. If we don't have that, we clamp the tube first and then disconnect before doing anything. Just one comment on sorry, on clamping the tube, that المفروض نعملها carefully, not to damage the tube. Like you don't want to cut the tube or damage the tube and need to re-intubate the patient. الصورة دي is close to what we do here actually في المستشفى اللي أنا شغالة فيها. We don't use, I know there is intubation boxes are like very popular these days, but I haven't seen it myself and I haven't used it. بنستعمل البلاستيك drape same like in this picture, and it's very simple, like it's not يعني هي البلاستيك دي ما حاجة كانت specifically for intubation. It's just a plastic sheet which I'm sure can be available في السودان. So we use it to transfer the patient from the ward to the theater where we do the intubation, or to ICU, and then we use it during intubation. So you tell the patient that I'm going to cover you with plastic cover, and it's transparent, which is easy in that you can do your mask ventilation under it. Even you can do your intubation, like you just بترفعها شوية لما تكون عايز تعمل الانتubation. حتى even بنستعملها for a non-COVID patient. We use it for all the intubation these days. Like any patient coming to theater these days can be like potentially a COVID patient. So we use it during intubation and extubation. I think this is one of the very simple measures that can be used in Sudan. Dear emergency checklist. It's by the Royal College of Anaesthetists, UK. أنا very fan like بالchecklist. بحب الchecklist شديد وبفتكر إنه it help a lot. I can share a link for this checklist في الكومنتس. وبتخيل إنه ممكن you can print it out وفي A4 paper وتعملوا لها lamination وتتعلق في الثياترز إذا هي ما عندكم أصلاً. التشيك ليست بتريحك بإنه أنت you don't miss أي حاجة. الزمن الأسي ده يعني it's a difficult time for everyone because like إحنا we are not used لإنه نكون لابسين PPEs while doing intubation ولا while working. الماسك مرات you feel يعني أنا I myself بتكون حاسة إنه أنا ممكن أكون ما قادرة أركز يعني وأنا لابسة الماسك وممكن تكون تحس إنه أنت it's hard to breathe even. ف too many things going around وكل يوم في قرار جديد ولا في قانون جديد ولا في حاجة جديدة في المانجمنت تغيير. فأفتكر إنه إذا في أي حاجة بنقدر نعمل لها check list it's good do it. حتريح روحك حتريح الاستاف اللي معاك. People can go through checklist very quickly يعني قبل الintubation make sure everything is ready and then start to avoid إنك تعمل mistakes to avoid missing حاجات in the middle. فدي واحدة في كم checklist لسه تاني حنتكلم عنها لقدام لكن emergency tracheal intubation checklist is one of them. وأنا I recommend إنه الناس تعمل لها print out وتعلقها where إنه الناس محتاجة لها. إذا الناس بتعمل intubation في الحوادث علقها في الحوادث علق واحدة في الثياتر علق واحدة في ICU فتكون accessible وأي حتى even not anesthetist يعني before while you are preparing your intubation trolley ولا بتجهز لانك انت هتعمل intubation للعيان ممكن اي زول من الناس الاراوند كان go through checklist يكون بيقول فيها بصوت عالي والناس تشوف انه في شنو ناقص وفي شنو it's okay to go. طيب in case انه we have a failed intubation or difficult intubation which can happen دي حاجة قاعد تحصل frequently. We know that the recommendations كانت is to avoid using supraglottic airways and LMAs. But if you have a difficult intubation, go through the standard algorithm of difficult intubation. Both LMA, both IGEL, use your bougie, go through the algorithm and forget about you don't have to use the LMAs in COVID-19 patients. After you are done with your intubation, patient is intubated and everything is okay, we should cover the single-use equipment and dispose of it once the patient is in the area where rest of care will take place. Like if the patient say intubated in ICU, we are happy about our intubation and everything. We need to get rid of equipment that we use. So, and I'm not sure about the practice in Sudan and what if you are using a single-use laryngoscopes or do we wash it or do we disinfect it بطريقة معينة. لكن الادفايس إنه ممكن ناخد شيت جنبنا whatever available sheet available. إذا في حاجات single use like مثلا السكشن الsyringe that you use to inflate the cough, the laryngoscope itself if it's disposable, ناخدها كلها في الشيت and dispose it في proper place instead of إنه لأنه لو خليناها ممكن someone else هيجي هيهبشها والحاجة دي كانت في الايروي بتاع الكوفيد patient وده risk of infection للstaff. إذا عندنا حاجات reusable we disinfect it according to the manufacturing instruction. Then the last step is that you need to take off your PPE لما تكون عايز تطلع من patient room. Pay careful attention to not contaminate yourself or others. Taking off the PPE again, is very important. And this is the second checklist for me, or second or protocol. Again, you need to take the PPE. I'm sure there is lots of videos and كلام يتقال في موضوع ال PPE, لكن it's very important إنك to take off the PPE in the right order. لأنه if we do it wrong, ممكن we can ruin كل الحاجة اللي عملناها دي. يعني أنت you did everything right and then you take your PPE in a wrong order, in a wrong way, you can still infect yourself. You risk إنك أنت infecting yourself. So to make it easy, I do recommend again في different ways of taking off the PPE. ما في حاجة يعني in my hospital if I go to ED they do it differently. I do it differently in theater. يعني بيختلف من الثياتر للحوادث، بتختلف الطريقة الناس المتفقين عليها إنه بيطلعوا بها ال PPE. لكن whatever طريقة هي مخطوطة في برضو again we can agree on الطريقة اللي احنا حنستعملها في الهوسبيتال بتاعتنا. printed في A4 paper, laminated, and again نخطها في الحتات نعلقها where people take off their PPE and do الdoffing. Again it's easy, بتخلي الناس ما تتلخبط, which is الواحد ممكن يكون very tired taking off their PPE وبس بيطلعوا بأي طريقة. يعني ممكن تتلخبط في الأوردر يعني easy, يعني إنه I take a mask first ولا I take a shoes ولا I take a gown. it's easy again. أعملوا A4 paper with the protocol whatever order you agreed on إنه دي right طريقة إنه زول يطلع بها ال PPE تتعلق في الحتة المفروض ال PPE تطلع فيها. So this is my second laminated protocol or checklist. كده هنكون خلصنا من موضوع ال airway. We intubated the patient if he needs intubation. The first practical guide that I wanted to share with you. السكند حاجة هي ال breathing and ventilation. وأنا هقول إنه أنا في البرزنتيشن ده I'm not gonna say anything about how to ventilate, like mechanically ventilate a patient in ICU, because this is a big topic. One I think it needs like a separate presentation. For breathing and ventilation, we all know that respiratory failure is a hallmark of severe COVID-19 infection. And we agreed that there is no specific treatment and the patient needs respiratory support. So there is different types of respiratory support people all around the world has been using since the start of COVID-19. And actually it kept changing. Like when the pandemic started, they used to say it's contraindication to use high flow nasal oxygen and CPAP because of the risk of aerosolization. Then few weeks later, الحاجة دي اتغيرت, and now, for example, here we are using it. I know some places are still against it and they don't use it. And I'm not sure if you have high flow nasal oxygen in Sudan or not. In UK, 60%, around 60% of patients receive non-invasive forms of respiratory support, different non-invasive forms like high flow nasal oxygen, CPAP, BiPAPs. Again, these are, like as I said, it was contraindicated at the start of the pandemic, and that's mainly of the risk of aerosolization, plus the concern over the high oxygen consumption, because you consume you need يعني very high oxygen, which can be a problem. And people were concerned about the hospitals running out of oxygen at the start with increasing the number of patients. So this is one of the disadvantages of using the non-invasive ventilation. The high flow nasal oxygen has been demonstrated this before the COVID-19 actually. from the studies before the COVID-19, we know that the high flow nasal oxygen has been demonstrated to reduce 90-day mortality in non-COVID-19 acute hypoxic respiratory failure, including the ARDS. So that's where like a use of high flow nasal oxygen come into the COVID patients. There is few consideration for CPAP and high flow nasal oxygen. أول حاجة, you need to clarify the ceiling of care and inform ICU if appropriate. Say you have a patient coming to ICU or actually coming to ED with increased work of breathing. Say the patient initially can face mask or non-rebreather, you're giving him 15 liters of oxygen and he starts deteriorating, his saturation is dropping, his work of breathing is increasing. So you are considering a CPAP or high flow nasal oxygen for that patient. It's okay to do that, but you need to clarify the level of care that you are going to give to this patient. What is your second step? Say, if he is deteriorating, there is a high chance that he might not respond to the CPAP, say. So you need to know, am I going to take this patient to ICU after or not? Like if he failed this CPAP or failed this, the non-invasive, am I taking him to ICU? Do I have ICU bed in the hospital? Do I need to transfer them somewhere else? So it's better, like when you are considering the CPAP or high flow nasal oxygen, at that point to discuss the level of care with the family, with the patient himself, if he can, and to inform the ICU that you have a potential patient that a patient might come at any point, instead of it happening like 2 o'clock in the morning and no one knows like what is the plan for this patient. Are we gonna just keep him on CPAP ولا حنوديه ICU ولا حنعمل له intubation ولا خلاص. If he improves, that's طبعا حاجة كويسة. طيب. Comply with locally agreed infection control measures. في different measures and في different concerns about the non-invasive ventilation in COVID patients, as I mentioned earlier. إنه هي risk of aerosolization, definitely. It's very high risk for the staff. So we need to make a plan, like إنه إحنا حندي العيان ده الCPAP ولا الهاي فلو نيزل أكسجين دي حنعملها وين؟ هل حنعملها في single rooms؟ هل عندنا negative pressure rooms؟ هل حنعملها في مركز العزل where all the patients are COVID positive and ما في risk for them، لكن حيكون في risk للstaff definitely. So we need to make like local guidelines and local measures with infection control and agree on it. Different hospital عندهم different protocols. Definitely, staff must wear appropriate PPEs at all time. Staff caring for patients with non-invasive ventilation with COVID-19, confirmed COVID-19, should wear ويكونوا لابسين ال PPEs بتاعتهم. As I mentioned في النقطة الأولى إنه مفروض نكون عارفين إنه rapid escalation of care is available if needed and if agreed on. اللي هو most likely if the patient failed an invasive ventilation, the next step, that means he's going for mechanical ventilation and he needs to go to ICU and mechanically ventilated and sedated and كل الحاجات. طيب. Once we start the patient on CPAP or high flow nasal oxygen, you need to know if he's going to respond or not. So ideally we should assess them within 30 to 60 minutes. تجي راجع بعد ساعة تشوف في improvement ولا ما في. Unless you have a risk of hypercapic type 2 respiratory failure, ما حتكون محتاجين العيان ده يكون عنده arterial line وإنك تعمل frequent blood gas sampling. You can go with the SpO2. So all you need is pulse oximeter, and you can assess يعني إنه هل improved or not. Maybe can desaturating on the non-rebreather mask وانت خدته في CPAP عايز تشوف إنه his oxygenation has improved or not. You can tell by that. Suggested initial settings, this actually from a paper in UK. They said flow 40 liters per minute. And الكلام اللي أنا قبل قلته عن إنه ال high flow nasal oxygen بتستهلك كمية كبيرة من الأكسجين. So and I think إنه even 4 liter يعني is too much. In my hospital يعني أسي إحنا بنستعمل maximum is 30 liters وده concern mainly إنه we are going to consume too much oxygen. So if the patient needed more than 30 liters per minute في الward, we go for intubation, we go for early intubation. So again, this can be modified according للsettings بتاعتنا لأنه عندنا أكسجين عندنا central oxygen, are we using cylinders, عندنا stock قدر كل شنو من الأكسجين, عندنا patients قدر شنو. في حاجات كثيرة you can modify according للresources بتاعتك. يعني ما في حاجة بتقول إنه إحنا we have to follow مثلا what is going in UK or what is going in America. We can modify management بتاعنا according to our resources and according to our like how many patients do we have. Obviously we titrate ال FiO2 لل level بتاع الhypoxia and we aim for 94 to 96%. Unless لو البيشنت عنده risk بتاع type 2 respiratory failure, you might aim for 88. If the patient is supine, البيشنت اللي انت خدته في CPAP ولا في high flow nasal oxygen, it's recommended إنهم نرفع راس السرير ونخليهم sitting 30 to 60 degrees. This will help with the oxygenation. Suggested initial settings لل CPAP, you can start with 10 centimeter water, and again the FiO2 is titrated ل SpO2 of 94% to 96, and this again يعني انت you take in consideration ال pre-morbidity تحت ال patient, ال situation حقت اللنجز بتاعته, is he smoker, non-smoker. So you make your target according to the patient condition. لو الحاجات دي كلها failed or even without failing, we can consider proning. And the most important thing is that you check the SpO2 after every change of position or change of settings. لأنه we need to follow this patient. We need to know if the change اللي إحنا we did that, is it making any improvement or not. And I found the patient lying supine. I asked the nurse, well, I asked even the patient to sit him up. I come after half an hour and see if that make a difference or not. We can consider proning, and I'm going to talk في موضوع الproning ده in details in a minute. طيب, you have the patient in CPAP, high flow oxygen. You ask them to prone, self-prone, or sit up. If with all that patient is still deteriorating and his saturation is not improving, his work of breathing is increasing, so we should consider immediate escalation of care or intensive care admission. Because if the patient إذا هم ما improving في الCPAP وفي كل الميجرز اللي إحنا عملناها دي, there is no point of just continuing. You can continue by like making change, like if you still have a room to go high with the flow, or to go or to change the settings or the level of support that you are giving with the CPAP. But if إنه الحاجات دي كلها ما improving your patient, you should consider other intensive care, escalation of care. You should consider something different. طيب الحاجة الثيرد practical guide هنتكلم عنها هي البرونينج. And this picture show like a typical proning team. I'm going to talk about the proning team بعد شوية. So we can see in this picture we have most likely someone اللي قاعد في راس العيان حيكون anesthetist, and then we have 3 people on each side to help with the proning. طيب prone positioning in comparison spine positioning has been demonstrated to improve oxygenation and decrease the mortality in mechanically ventilated patients with moderate to severe ARDS. This is coming before the COVID-19 pandemic. We know that proning positioning help improve oxygenation and decrease the mortality في ARDS patients. طيب, we can do proning in self-ventilating patient. We can ask the patient في العنبر قبل ما يجوا even للintensive care أو قبل ما يحتاجوا HDU or قبل ما يحتاجوا much support, we can ask them to self-ventilate. طيب, أي عيان في العنبر أو في الحوادث that محتاج ل FiO2 of 0.28 عشان الساتوريشن بتاعه يبقى 94 to 95%, we can ask them to self-prone. الself-proning اللي هو simply انت you ask the patient إنه to lie on their tummy, قول لهم أرقد على بطنك as much as possible. الموضوع ده ما محتاج specialist, very simple, العيان ممكن يعملوا براهو, ما محتاج أي additional equipment. العيان ممكن يكون في اللحظات دي هو بياخد أكسجين بفيس ماسك, ممكن تكون خدته في CPAP, ممكن يكون بهاي فلو nasal oxygen. ما محتاجين إنك to give him any sedation to do that. وبنقول لهم lie on your tummy as much as possible. هي sometimes ممكن تكون ما مريحة بالنسبة لهم, ممكن they might not tolerate it. someone عنده يعني هو أصلاً difficulty breathing ويرقد على بطنه, ممكن يزيد الموضوع زيادة شديد, يعني ممكن يكون هو ما قادر to tolerate it. لكن as much as they can tolerate it, you tell them إنه هو ممكن يرقد على بطنه. طيب, في الميكانيكالي ventilated patients it's a bit different وممكن يكون complicated procedure actually. You need more staff, you need حاجات كثيرة هقولها هسه. طيب, الميكانيكالي ventilated patients who respond to prone positioning اللي هو كيف هنعرفهم responded, this demonstrated by an improvement in the oxygenation, should remain prone for up to 12 to 16 hours at a time. And then we repeat on a daily basis till oxygenation improve. Usually COVID patients, they need like maybe 5 cycles of proning and unproning. لكن if they are responding and we think that their oxygenation, their PO2 is improving or their FiO2 is decreasing with proning, بنخليهم prone لمدة 12 ل 16 ساعة ونريبيت الحاجة دي every day. يعني يكونوا prone say 12 hours and then we unprone them, نخليهم يركضوا على ظهرهم 8 ساعات and then reprone them. الحاجة دي بتتعمل on daily basis. طيب, indication for proning في mechanically ventilated patient إنه يكون PF ratio بتاعهم less than 150. There is another consideration, but this is like just to simplify القصة بتاعت proning. Contraindications, there is an absolute contraindication لإنك to prone someone and there is relative contraindication. the absolute contraindication for chronic, and this الليستة دي بتنطبق على الناس السيلف فنتيليتنج وعلى الناس الميكانيكالي فنتيليتد. طيب if someone need for immediate intubation، يعني انت جيت الوورد لقيت العيان الwork of breathing بتاعه very high، الريسبيراتوري rate بتاعه up to say 40 something and he's desaturating, or he can't speak, he can't complete a sentence. This looks like someone who needs intubation. Proning is not going to do anything for him. ما ممكن to ask him to prone at that point. This is like one of the contraindication for proning, need for immediate intubation. Significantly, hemodynamic compromise. Patient intubated, he is on high NORAD, he's tachycardic, has some sort of arrhythmia at that point. Again, we can't prone them. Agitation and altered mental state, again, you can't prone someone like that. And even if they are tubed, you need to keep them like deeply sedated, paralyzed before proning them. Chest injury and unstable spinal injury, this is like the obvious, يعني إنه the contraindication للproning. Relative contraindications for the proning, someone عنده facial injuries، لأنهم when they are prone حيكون وشهم لتحت، أصلا هم بتحصل لهم facial edema from the proning. ف it depends، يعني ال facial injuries is it minor, major، حاجة كتيرة. It's like هي عشان كده دي relative contraindication. Other relative contraindication: seizures, morbid obesity. Morbid obesity ممكن يكون very difficult to prone. ممكن you can compromise their ventilation actually when you prone them. هو ذاته حيكون you need more staff, you need more people in your proning team. حيكون risk of إنك أنت you can't pad all the pressure areas. They might end up with like pressure sores or ulcers. الحاجة الرابعة ال second or third trimester pregnancy and anterior pressure source و recent abdominal surgery، دي كلها relative contraindication للproning. نجي للproning itself و my favorite checklist و team proning team. again دي واحدة من الحاجات اللي very important فيها إنك تعمل checklist عشان standardize of الكير، الناس كلها تكون on the same page، عارفين بيعملوا في شنو، عارفين بيعملوها كيف. المشكلة بتاعت البرونينج في الاي سي يو ان انت بتحتاج more staff، خاصة إذا عندك نقص في الستاف، دي مشكلة كبيرة. ال good news is that إنه ال proning team they don't have to be anesthetists and they don't have to be like ICU nurses. انت ممكن to make use of الدكاترة الثانيين اللي في المستشفى من التيمز الثانية اللي شغلهم أقل. all you need is that إنه أنت محتاج تعمل لهم teaching وتعمل لهم training how to prone. وأجين محتاجين نعمل checklist للproning ونعمل protocol or طريقة معينة لأنه نعمل بها standard طريقة نعمل بها البرونينج. again and I can share with you في comments one of the checklist and one of the ways إنك تعمل proning، يعني step 1 تعمل شنو، step 2 تعمل شنو، step 3 تعمل شنو، اللي هي دي بتحاجة بتخلي عندك standard of care. وبتخلي الناس إذا هي الناس بتعمل نفس الحاجة كل يوم بنفس الطريقة هتكون less chances of إنه الناس تغلط فيها أو تعملها بطريقة غلط. المشاكل بتاعت البرونينج للعيان الفنتيليتد إن أنت عندك patient intubated، ما عايز يحصل dislodgement للتيوب بتاعتك، ما عايز أي disconnection، لأنه أي disconnection معناها more aerosolization more infection للستاف. الحاجة الثانية العيانين في الاي سي يو غالبا بيكون عندهم arterial line central line، بيكون في infusions running، عندك مثلا 2 sedative medications running، عندك NORAD running، ففي too many lines، عيان catheterized، فالعيان كله بيكون connected لتيوبس وكاثيترز وبلس ال ETT تيوب بتاعتك. فما عايز to lose any of these tubes ولا يطلع line بالغلط. ف it has to be done يعني in very careful way. Well, people who are doing the proning, they have to get training في موضوع البرونينج ده. لما أقول training, it's not حاجة صعبة. They just need to practice. the person at the top or at the head of a patient has to be an anesthetist, وهو ممكن يكون a team leader. هو اللي بيوري الناس when to prone, when to turn, when to stop. لو في أي حاجة هو هيكون التيم ليدر. لكن زي ما قلت محتاج minimum of 6 people اللي هم 3 في كل اتجاه عشان يساعدوا إنه يقلبوا العيان على بطنه. الستة التانيين غير الانستيست ما محتاجين يكونوا. أفتكر أن I mentioned that already. They don't need to be an anesthetist. They don't need to be ICU nurses. فأنت ممكن they can be part of the other teams اللي هم شغلهم بقى أقل. surgical registrars ما عندهم elective list لكن they can help in ICU. They can help with موضوع البرونينج ده. أنت you save your ICU staff, save their energy, save their time بإنك أنت you are using other resources في المستشفى. It can be anyone. ممكن البورترز you can train them. ممكن الكلينر لو عندك كلينر في الاي سي يو ممكن you can use them as well. الفكرة كلها إنه أنت تعمل dedicated team. تعمل لهم training. الناس ممكن you can practice by someone من التيم ذاته. Definitely they are not going to practice في البيشنت أول مرة. فهم they are going to practice. well sessions دي it takes like 10 minutes عشان تشو الناس كيف إنه يعملوا البرونينج. فممكن الناس تعملها مثلا في واحدة من الثياتر رومز. تشوف الناس الانترستد إنهم يبقوا parts of your proning team. تدربهم تعلمهم. بعد ذاك الناس بتتفق لو في عيان في الاي سي يو needs proning. usually عشان to make الحاجات سهلة they can agree مثلا إنه 8 o'clock in the morning is a time for proning. فالناس التيم ده بيجي بيلبس ال PPEs بتاعته help you with the proning and then they leave. Okay. You can tell them في نفس الوقت إنه إحنا we are gonna unprone البيشنت ده الساعة 4 ظهر بعد ما يتم ال8 ساعات بتاعته ولا ال 12 ساعة بتاعته. هم الساعة 8 والساعة 4 المفروض يجوا عشان يقلبوا العيان تاني على ظهره. فالحاجة دي إذا اتعملت لها تشيك ليست، إذا اتعمل لها local protocols and guidance. وagain I recommend إنها تكون written وتكون available for everyone. Plus someone اللي هو ممكن يكون التيم leader can do checklist at the start, make sure everything is in the right order. Can go very smooth. It can benefit المانجمنت بتاع العيان. طيب كده نجي للحاجة نمرة 4 أفتكر في ال practical guide في management of COVID patients which is related لل cardiovascular system. طيب العيانين بتاعين الكوفيد pre-existing cardiovascular disease is very common in COVID-19 patients. They found إنه في 17% منهم عندهم hypertension, 16% عندهم pre-existing. This is pre-existing ischemic heart disease. The heart failure has been seen in up to a quarter of COVID-19 patients, with almost half having no prior history of heart disease. ما كان عندهم أي heart disease قبل كده وجو بheart failure مع الكوفيد. Plus ده كله ممكن يكون combined مع right ventricular failure اللي هي تيجي مع ARDS. طيب COVID-19 they found that إنه في association between myocardial injury and myocarditis. وده كان حاصل even before COVID-19 مع الكورونا فيروسز كلها. It's very difficult to differentiate إنه العيان ده عنده myocardial injury في اللحظات دي ولا دي viral myocarditis. troponin ممكن يكون high فيهم الاثنين. الاي سي جي changes ممكن تكون similar وممكن تكون very difficult انك to differentiate between المyocardial injury and myocarditis. bedside echo can be very يعني helpful to differentiate between الاثنين ديل. Again, we can get like someone to do bedside echo. الكارديولوجي تيم في المستشفى ممكن to get involved في المانجمنت بتاع العيانين بتاعين الكوفيد. They can help with إنهم يعملوا bedside echo. ده will help إنه نعرف إنه العيان ده what's wrong with them exactly. Some intensivists are happy to do their echo by themselves. And due to the systemic inflammation and hypercoagulable states بنشوفه في COVID-19 patient, هم are at increased risk of acute coronary syndrome including ST elevation and non-ST elevation myocardial infarctions. This just عشان حاجة الناس تخطها في بالها إذا العيان جاب ST elevation he can be COVID as well. طيب الحاجة الخامسة في البراكتيكال جايد هنا حنتكلم عن الفيزو اكتيف ايجنت. patients in like this for patient definitely in ICU and most likely they're going to be mechanically ventilated. طيب according لل sepsis guidelines we should aim for a map of 60 to 65 millimeter mercury. أنا حاجة أتكلم later عن إنه العيان ليه أصلاً ممكن يكون هو hemodynamically unstable ولا يكون محتاج vasopressors. Noradrenaline should be used as the first line agent. عندك عيان hypotensive or shocked, so we need noradrenaline. اللي هو دي قبل لما عملت الintubation and you stabilize your عيان, most likely you do intubation, put your arc line, your central line straight away after intubation, and this patient is most likely is going to end up إنه يحتاج vasoactive agents. So noradrenaline should be used as a first line agent. لو ما عندنا noradrenaline ال second option إنه نستعمل adrenaline or نستعمل vasopressin, ممكن نستعملهم الاثنين. أو إذا العيان ما responding للnoradrenaline, sometimes العيان أنت you start him on NORAD and still ممكن يكون shocked, still ما قادر ترفع البلد بريشر بتاعه, ف it's recommended إنك أنت to use vasopressin on top of the NORAD. العيانين لو أنت شايف إنه العيان عنده evidence of cardiac failure either بالإيكو أو clinical examination, they might benefit from dobutamine in addition للnoradrenaline. And this like العيان يكون hyperperfused despite appropriate fluid resuscitation. حاجة أتكلم عن fluid resuscitation. طيب bad news إنه COVID-19 patients with underlying cardiovascular diseases are more likely to require intensive care, and once admitted to an intensive care unit, they have a higher mortality rate up to 5-fold of some studies. Actually, السلايد دي كان المفروض تجي بعد cardiovascular problems, not بعد vasoactive. لكن this is what we know. إنه إذا جاء COVID patient في الحوادث وهو أصلاً عنده pre-existing cardiovascular disease, most likely إنهم حيكونوا من الجروب اللي حيحتاج intensive care, و unfortunately إنهم لما يدخلوا intensive care المورتاليتي بتاعتهم higher than someone من غير cardiovascular problem. طيب الحاجة الثانية في related للكوفيد الthromboprophylaxis and anticoagulation. At this stage, we all know COVID is like associated with hypercoagulable state, or who are hypercoagulable actually. You can use both low molecular weight heparin or unfractionated heparin. Both are being used. I'm not sure which one is available in Sudan or which one الناس بتستعمله. Just one point إنه we should pay special consideration in patients with renal impairment. لو العيان عنده renal impairment مفروض نشوف ال right dose for them عشان انت ما عايز to overdose them with الheparin. والrenal impairment is very common in patients with COVID-19. The last point في الثروmboprophylaxis إذا عندك high index of clinical suspicious that the patient has a PE and there is signs of having hypercoagulable state such as إنك عندك high inflammatory markers, therapeutic anticoagulation should be considered even imaging is delayed or unavailable, as long as there is no contraindication. We can start the therapeutic heparin if there is high index of suspicion of PE. You don't wait for CT, especially لو ما available CT immediately. طيب. النقطة الثانية في البراكتيكال جايد هو السيديشن في الاي سي يو. From the cases that جات all around the world since the start of the pandemic, they found that in patients with COVID-19 they require higher doses of sedative medication than would be expected in similar mechanically ventilated patients with respiratory failure from other causes. So هنحتاج more sedation and هنحتاج more sedative medications. ودي ممكن تكون مشكلة وممكن تكون ضغط على الهيلث سيستم بتاعنا إنه اليوز بتاع السيداتيف ميديكيشنز حيكون كتير. ما في حاجة is superior يعني ما في medication هو superior للتاني. So use whatever is available. Use opioids, use benzodiazepines, use propofol, whatever you have in your hospital, just use it. And another thing is that في regular theater, if you can avoid يعني GA, if you can do أي حاجة regional technique or spinal anesthesia, do it. عشان to save sedative medications للpatients في ICU. Plus don't use مثلا TIVA الأيام دي عشان again to save not to consume too much مثلا propofol ولا remi if it's available يعني. طيب حاجة مهمة جدا الفلويد بالانس في الكوب. البيشنتس بتاعين الكوفيد 19 most likely they may present dehydrated already. لما يجوا للحوادث ممكن يكون هم already dehydrated. They have been sick for few days or for weeks. الأورال intake بتاعهم بيكون قل كتير by the time هم بيجوك في الحوادث. They don't drink sufficiently. They don't eat. فممكن يكونوا already sometimes بيكونوا جايين ب GI symptoms, يكون عندهم diarrhea, vomiting. So في factors كتيرة بتخليهم already dehydrated. Dehydration may contribute ل higher than expected rate of acute kidney injury. وعشان كده ممكن يجيهم acute kidney injury. ممكن يكونوا at high risk of increased thrombosis. وممكن يحصل لهم VQ mismatching. ده كله بسبب severe dehydration. So what is recommended إنك to do initial resuscitation with crystalloids. Again, whatever is available. Ideally, we should use lactated ringer or use normal saline. أنا ما أعرف الفلويدز المتوفرة في السودان شنو. لكن use crystalloid, balanced crystalloid for an acute resuscitation of shock patient. Once إنه patient is fully resuscitated, بعد ذاك then we aim for euvolemia. it's not recommended إنك to overload the patient, and it's not recommended إنك to use like liberal use of fluids. So aim for evolume. In case إنه the patient is edematous, we can use diuretics, especially في say patient mechanically ventilated. هم بيكونوا بياخدوا fluids كثيرة بسبب إنهم infusions الانتيبيوتكس اللي بياخدوها plus إذا كانوا بياخدوا في IV fluids, so they might be overloaded. فممكن نستعمل diuretics to reduce the edema in the absence of evidence of cardiovascular instability, poor perfusion, and shock. We make sure that the patient is cardiovascular stable, he's not poorly perfused, and he's not shocked. Then you can, and the patient is edematous, so you can use diuretics. Type. A conservative fluid strategy aiming for euvolemia has previously been demonstrated to improve lung function, reduce the duration of invasive ventilation and length of ICU stay without increasing extrapulmonary organ failure in acute lung injury. So we use a conservative fluid strategy and we aim for euvolemia. And we can use a fluid balance, check a urine output. There is different ways إنك تعرف إنه العيان euvolemic or not. طيب أفتكر دي last system هنتكلم عنه اللي هو renal system, which is very important في COVID-19. Acute kidney injury is common في COVID-19 patients. Up to 35% of cases في ال ICU في UK عندهم حصل لهم acute kidney injury, و over 20% of COVID-19 admissions to UK ICUs احتاجوا renal replacement therapy. Pathophysiology ولا why do this patient get acute kidney injury مع respiratory failure بتاعته؟ ممكن يكون too conservative fluid strategy. إحنا we are drying the patient too much to the extent إنه هو hypovolemic وممكن يحصل له renal injury, أو renal microthrombi as we said إنه الكوفيد هو hypercoagulable state والpatient بيكون بتحصل له microthrombi, ممكن تكون في اللنس ممكن تكون في أي organ تانية, أو بيكون direct viral injury للrenal tubules. Again, it can cause acute kidney injury. So, patient coming to ED with oliguria, أو عملت الانيشال بلوتس بتاعتك لقيت high creatinine high urea, خد في بالك إنه ممكن يكون ده acute kidney injury وتكون secondary للCovid-19. طيب. Some centers have developed protocols for the delivery of intermittent hemodialysis and peritoneal dialysis, as well as utilizing higher rate of renal replacement for a shorter period of time, so as to allow sharing of hemofilters between patients. As I said في قبل إنه إحنا we have to use a resources بتاعتنا and to tailor it للأول manage بتاعنا نعمله على حسب الريسورسز بتاعتنا. فكل العالم struggling من high number of patients في ICU وإنه في low ICU beds و definitely في low like ما في enough dialysis centers. So you make your own protocols and guidelines according to what you have. في centers according للسلايد دي إنه في centers عملوا protocols لإنه يعملوا intermittent hemodialysis ويعملوا peritoneal dialysis ويعملوا renal replacement ل shorter duration عشان يقدروا to manage many patients at the same time. So hopefully we don't get to that stage إنه إحنا عندنا عيانين كتار محتاجين renal replacement therapy, but if they need it we have to find a way إنه إحنا how to dialyze العيانين بتاعنا في ICU. طيب دي خلاص كده practical guides انتهت. I didn't go through the ventilator settings or how to ventilate the patient. As I mentioned, إنه ده أفتكر إنه ده topic كبير ومحتاج إنه يتعامل براه. or actually كل الحاجات دي يعني each one يعني cardiovascular disease and COVID patients, renal disease and COVID patients, كلها أي واحدة منها كانت ممكن تكون different topic, but I حاولت إنه بس أغطي حاجات كثيرة practical ممكن تكون مفيدة. الكونكلوجن بتاعتي هقول إنه التشيك ليست and laminated protocols for أعملوا check list for intubation, أعملوا check list for donning and doffing, أعملوا check list for the proning. Whatever you can do check list for, do it. Whatever you can do your local protocol as far as إنها ماشية مع البروتوكولز البروديوس من وزارة الصحة ومن الانفكشن كنترول. We can do our local protocols, adopt it, teach your staff على وريهم الحاجات دي. Deployment of other teams in the hospital. استعمل كل الhuman resources اللي عندك مع lack of staff. As I mentioned في presentation, you can إنك تستعمل تطلب help من ناس الكارديولوجي مثلا، ممكن يكونوا هم بيجوا بيعملوا bedside echoes في ICU للعيانين المحتاجينها. ممكن تستعمل أو نعمل التيم بتاع البرونينج من different staff في المستشفى. ممكن يكونوا دكتورز ثانيين، ممكن يكونوا بورترز، ممكن يكونوا كلينرز، ممكن يكون أي زول، بس as far as إنك أنت حتعلمه. Adopting local guidelines and protocol to suit resources and number of patients. ودي حاجة ممكن تكون as we can see من بداية البانديميك لحد أسي الحاجات دي بتتغير on daily basis. فإحنا ممكن نكون مواكبين ونغير الحاجات according للحاصل عندنا الليلة عندنا 20 عيان ولا عندنا 100 ولا عندنا 5. ف we can change البروتوكولز بتاعتنا according للريسورسز بتاعتنا ولعدد البيشنتس حقيننا. الحاجة المهمة مهمة جدا continuous teaching, continuous training للدكتورز، للنيرسز، للأذر ستاف. الموضوع بتاع التيتشنج ده ممكن يكون very simply يعني ما إلا تجيب جروب كبير أو actually إحنا مع السوشيال ديستانسينج we shouldn't get جروب كبير عشان نعمل له teaching، لكن ممكن on a daily basis نعمل teaching للناس على إنه يعملوا proning كيف للعيانين. ممكن نعمل teaching للستاف بتاعنا donning and doffing للPPEs كل يوم. فممكن يكون في زول واحد أو زولين هم بيعملوا الحاجة دي on a daily basis. انت كده بيكون عندك بتكون عامل continuous teaching. لو في اي حاجه جديده ممكن نعمل برضه نعمل orientation للناس بيها. لو دخلت اي حاجه جديده مثلا في الانتيوبيشن if you get video laryngoscopes وعايز الناس to train ممكن you can do مثلا daily sessions with that. That's it I think. وشكرا جزيلا على وقتكم، وأتمنى إنه يكون الكلام مفيد. ولو في أي زول عنده سؤال ما عارفة يعني في أي أسئلة أو.
شكرا دكتورة، الله يديك العافية. ما في أي أسئلة.
طيب. شكرا جزيلا لكل الناس. شكرا لك يا نهى، والسلام عليكم ورحمة الله.